Welcome everybody to today's presentation from the VCCC relating to global health. I'm Michael Sullivan, paediatric oncologist from the Royal Children's Hospital, and I lead the Royal Children's Hospital Global Health and the International Society of Paediatric Oncology Global Health Network. And before we begin today, I'd like to acknowledge the traditional custodians of the lands in which myself and today's presenters and audience are located. I'd also like to pay respect to elders, both past and present, and extend our respect to other Indigenous Australians present online. Before we begin today, just some housekeeping. Today's webinar is being recorded and will be made available on the VCCC Alliance Open Learning page once the presentation is compiled and published. If you have any questions today, can you do this through the Zoom Q&A function? I'll take note of the questions and answer those at the end. Today, I'd like to introduce our presenters. We have three presenters today. Dr. Iain Ward trained as medical oncology and radiation oncology in both Christchurch and Melbourne. His particular interest in global oncology and is co-chair of the Asia Pacific Radiation Oncology Special Interest Group, which supports low and middle income radiotherapy departments in the Asia Pacific through bilateral exchange, training and education. Dr. Ling Yap is a staff specialist radiation oncologist at Liverpool and MacArthur Cancer Therapy Centres. Dr. Yap is co-chair of the RANSCAR Special Interest Group. She is also a member of the Global Task Force in Radiotherapy for Cancer Control and co-author of the Lancet Oncology Commission. She sits on the steering committee of the Global Impact of Radiotherapy on Oncology. She also holds a conjoint senior lecturer appointment at the University of New South Wales and Western Sydney University, and an adjunct senior lecturer appointment at the University of Sydney. She's currently completing a PhD in health services research at the University of New South Wales. Dr. Nikki Shelton, our third speaker, is an experienced radiation oncology medical physicist at the Olivia Newton-John Cancer and Wellness Centre. She's a demonstrated history of working in senior roles dedicated to contributing to development of in the field of medical physics. In 2018, Nikki and her family spent 12 months in Cambodia, where Nikki volunteered as a medical physicist trainer, teaching the local team how to commission and safely implement their treatment planning system, linear accelerator and brachytherapy unit. Since returning to Melbourne, she's taken a lead role in implementation of magnetic resonance imaging and radiotherapy at the Olivia Newton-John Radiation Oncology Centre. Today, as I've mentioned, we will have Q&A through the Q&A chat, and I'll invite Dr. Ling Yap to begin the presentation, followed by Nikki Shelton and then Iain Ward. Thanks.
Okay, I'll just share my slides. How's that?
Yeah, that's great, thanks.
Okay, so thank you, Professor Sullivan, for the introduction, and thank you, Cynthia, for inviting us to present today. So the way we're going to divide up the talk, firstly, I'm going to speak about some of the evidence supporting the need to expand radiotherapy access in low and middle income countries in our region. And I'll also talk on APRASIG, our organisation's pre-pandemic approach to supporting radiotherapy in APAC low and middle income countries. Then Nikki is going to continue on to give an on-the-ground perspective of the successes and challenges of training local radiotherapy staff in an Asia-Pacific low and middle income country. And then Iain will finish off talking about an Iaea virtual tumour board project that he's heading up, which empowers regional collaboration through online clinical networks, and then finish off by touching on some of our efforts to try to support our colleagues in research endeavours in the region. So just to start, we know that there's a huge demand for cancer services in the Asia Pacific. And when we've applied the CCOR optimal utilisation modelling, which uses the best available evidence to model the proportion of cancer patients who have an indication for radiotherapy, and we've applied that to Globocan cancer incidence data from Iaea, it's been modelled that close to 6 million cancer patients diagnosed in 2040 in the Asia Pacific will have an indication for radiotherapy. And what this means is that there are huge radiotherapy investment requirements in the Asia Pacific. And we've also modelled the current, well, in 2012, the supply and the demand of radiotherapy in the Asia Pacific. And what we found was that a number of countries in the Asia Pacific currently have a deficit of radiotherapy machines of over 200 in that country. And the Iaea has also then modelled the additional investments required for geographical region around the world for radiotherapy. And you can see that the Asia Pacific by far and away has the greatest investment demands when we compare it to other areas such as Africa, Europe, Latin America, and North America. So why should we invest in radiotherapy? We've also looked at the potential outcome benefits from radiotherapy in the different income groups of countries according to the World Bank definition. And you can see that it's actually low income and low middle income countries in which patients could potentially derive the greatest outcome benefits. So again, we've used modelling, which is the CCOR outcome benefits models, looking at across a cancer population, what proportion of patients would derive a local control or survival benefit from radiotherapy as opposed to any other cancer modality, and that's using best available evidence. And it's low and middle income countries where potentially the greatest outcome benefits could be derived. And the reason for this is that the cancer case mix in low and middle income countries tends to be different from that of high income countries. For example, cervix cancer is much higher incidence in low and middle income countries. And in the CCOR outcome benefit models, it's cancers such as cervix cancer, which can potentially derive the most local control and survival benefits from radiotherapy as opposed to other cancer modalities. And so, for example, with Cambodia, when we look across their cancer population, the proportion of patients that could derive a local control benefit from radiotherapy as opposed to any other cancer modality has been modelled to be 10% and 5% to derive a survival benefit. And we also know that cancer in Asia Pacific, low and middle income countries tends to affect much younger patients than in high income countries. So again, if we look at the Globocan data from Iaea, you can see that in Cambodia on the right, majority of patients who are diagnosed are under 65, as opposed to in Australia, where most of our cancer diagnoses are in the over 65 population. So if we can potentially cure patients from cancer who are under 65, we can then potentially have more patients or people contributing to the workforce. And so it has been already demonstrated in this Global Task Force of Radiotherapy and Cancer Control Lancet Commission paper that an investment in radiotherapy globally will lead to economic benefits, and that includes in low and middle income countries. So the Global Task Force brought together experts in radiation oncology, global cancer, and health economics to really make an investment case for radiotherapy that we could then take to policymakers to make sure that radiotherapy is included in comprehensive cancer planning. So you can see in this graph here, and what it looks at is the costs of radiotherapy, and certainly there needs to be costs to invest in radiotherapy. We have very specialized equipment and buildings necessary, but even when we use the most conservative modeling, that is the highest cost, which is the line in purple, and that's not accounting for things like automation or bulk buying, which would actually lead to lower costs, which is the green line. So even if we take the worst case scenario, which is the purple line in costs, and the red columns, which is economic benefits, just looking at human capital, and not accounting for a whole of society approach to look at economic benefits. When we look at the sort of most conservative modelling, if a country invests in radiotherapy, down the track, 10 to 15 years later, that country will start to reap economic benefits as a result of keeping patients contributing to the workforce. And then if we were to look at a less conservative model, then really those economic benefits are seen only a couple of years after investing in radiotherapy. So there certainly is a strong case for investment, even in low and middle income countries. But despite that, we still see a widening of the gap in terms of radiotherapy services in low and middle income countries. And these pie charts here show at the top the increase in cases over a decade in the cases that have an indication for radiotherapy according to the best available evidence. And you can see that the increase in cases over that time has been predominantly in low and middle income countries, that is the green, the blue and the red. But when we look at where radiotherapy machines are being installed around the world, the majority has been in high income countries in the orange, where the need is not as great. And that means that really the radiotherapy gap is continuing to widen in low and middle income countries, because even when machines are being installed, it's not actually accounting for the growth in cancer incidence, predominantly due to population growth. So for example, in Cambodia, in 2002, we modelled that there was a deficit of 13 radiotherapy machines in the country to meet the actual demand for radiotherapy according to their cancer incidence. And then even though one radiotherapy machine was installed during the decade between 2002 and 2012, the deficit in the number of machines actually grew to 16 because of that increase in cancer incidence over that decade. So we know that we need to expand radiotherapy in the area, but there are many challenges, and unfortunately, this would be a very long talk to go through all of these challenges, but certainly one of the main ones is workforce. And Cambodia is one in which there certainly has been a challenge in terms of radiotherapy workforce. Pre-2018, Cambodia is a country that, as you know, has suffered decades of tragedy. Although in the last decade, at least prior to the pandemic, it underwent rapid economic growth of one of the highest growing economies in the world. The estimated cancer incidence in the country, according to Globocan, is about 18,000 patients a year. And prior to 2018, they had access to pathology, radiology, basic chemotherapy agents, morphine, and one very basic Chinese linear accelerator, which you see in the picture here, which only works very intermittently. And you can see that picture at the bottom right as an example of one of their cancer clinics in 2016, where they were very stretched for space. Human resources challenges it's a huge challenge globally, and the Global Task Force paper modelled that over hundreds of thousands of radiotherapy professionals will be needed worldwide in order to close the gap in terms of services. And in Cambodia, if we were to meet demand, we would need over 100 radiotherapy professionals. At the moment, there are currently only about 20. And for example, currently in the pandemic at the Cancer Centre, which we've been collaborating with, only one radiation oncologist is still seeing cancer patients full time, and the others have been seconded to COVID wards. So the workforce is a huge challenge, and Nikki's going to go to that in more detail. But when we try to expand radiotherapy, because it's really a very specialized treatment that needs, trained staff that use high-tech equipment, it is a challenge if a country hasn't actually treated radiotherapy in that country before. They don't have that expertise. And some of the radiotherapy professionals, including radiation therapists and medical physicists, are not even recognized as professions in many countries around the world. So the National Cancer Centre in Phnom Penh is the centre which the three of us have been collaborating with. And this is a comprehensive cancer centre which was opened in January 2018. And I understand that Professor Sullivan is also collaborating with the centre. And this has been a project that was planned for over a decade. It provides chemotherapy, radiotherapy, haematology, nuclear medicine, as well as palliative care. And it currently has state-of-the-art radiotherapy equipment. I mean, the machine that it has really would be on par with radiotherapy machines in Australia and New Zealand, or even perhaps more modern than some radiotherapy machines that are available in Australasia. And their plan really was for this to be the flagship centre with a hub and spoke model across Cambodia, and with an eventual plan for 3 radiotherapy machines as well as a PET-CT, although I think these plans are really on hold due to the current pandemic. So we were all lucky enough to have been involved in supporting colleagues from National Cancer Centre for now the last 5 years or more. And we were able to visit in 2016 when the building was first in progress. And you can see from the timeline that it was quite a productive last few years, and in which the machine was installed, commissioned and opened. And we've been lucky enough to have Australasian staff present during these important milestones. And Nikki's going to outline really on the ground what it's been like to be a volunteer in this setting. So just a short word about the Asia Pacific Radiation Oncology Special Interest Group, APRASIG, which is the group that Iain and I co-chair. We're a volunteer organisation of radiation oncologists, and we're an interest group of the Royal Australian New Zealand College of Radiology's, the Faculty of Radiation Oncology. And there's about 90 or so fellows and trainees who are members of the organisation. What we do is aim to support radiotherapy professionals to develop safe and effective radiotherapy in low and middle income countries in our region. And our main activities include education and training, advisory roles, research and collaboration, particularly with the Iaea. And our partners include not only Cambodia, but also Mongolia, as well as PNG and Vietnam. So in terms of the initiative we've had with Cambodia, so our organisation APRASIG, as well as APSIG, the organisation that Nikki belongs to, the main way that we've tried to help to support in terms of education and training has been in-country training, that is Australasian trainers going to Cambodia to train local staff using the equipment that they will be then treating patients with and in their local environment. And we've favoured this approach because I think, you know, it makes more sense to train local staff in the environment that they're going to be working in moving forward, especially if they are then going to go on to also then train other local staff. So from April 2017, prior to the actual centre going live with treatment, there have been radiation therapists and physicist trainers that were there in country for periods of 2 to 15 months under the Australian Volunteers Program through DFAT, and Nikki will talk about this in more detail. And we've also had shorter team visits where we will have representatives from radiation oncology, physics and radiation therapy for specific topics such as cervix brachytherapy and clinical guidelines. Although our main way of providing support has been in-country in Cambodia, we also have hosted Cambodian professionals in Sydney a few years ago for a month duration under the Australian Awards program. And this included not only a radiation oncologist, but also other professionals across the cancer continuum. We've also supported Cambodian staff to attend conferences, and the photo at the bottom is Dr. Maura Mel, who gave a talk at our global health session in Auckland 2 years ago at our last RAS6096 meeting. And pre-pandemic, our plans were to have a 3-month radiation therapist and radiation oncologist posted in the National Cancer Centre for IMRT, a more advanced radiotherapy technique development last year, but our plans came to a halt with the pandemic. So you can see that the Cancer Centre had a very productive start, and these numbers in terms of patients show that it's been very productive with very little downtime. So they've treated 380 patients in the first 18 months or less on the linear accelerator, and 67 cervix cancer patients on their brachytherapy machine. And you can see that the highest incidence of cancer patients that they've treated has been in cervix. So you can see a very productive start to their service. And I'll now pass on to Nikki, who's going to then talk in more detail about her volunteer experience. Thank you.
Thanks, May. Yes, certainly I will launch into this as soon as I can share my screen. Go. That's a great introduction, May. Thanks very much. Just goes to show how long some of these projects take to get going. Now, can everyone see my screen? Oh, this one.
Not yet.
No? Share.
Yep, perfect. Thank you.
Great. So in 2018, I spent 2017, 2018, I spent 12 months with my family in Phnom Penh in Cambodia. Now, just before I go ahead and describe the partnerships, just briefly wanted to let you know that medical physicists, we're not in fact doctors, we're a group of medical scientists, and we specialize in the commissioning and implementation of the technology that's used. So in radiation oncology, you'll find us in diagnostic imaging and in nuclear medicine. Most of us work with ionizing radiation, and in my case specifically, the aim of my job is to create and maintain the treatment programs that the radiation oncologists want. And we look at it from a technical perspective. So the equipment and the software and the safety. So we do have some face-to-face interaction with patients. Often it's limited to certain treatment techniques, and you'll normally find us working in the background. So patient and staff safety is our primary focus, and accurate treatment is also another primary focus. So as May mentioned, I went under the Australian Volunteers for International Development Program. So they funded my 12 months as a volunteer. And this is a well-established program, and it's part of DFAT's commitment to working with low to middle income countries in our region. My how I got roped into this was through the Asia Pacific Special Interest Group, and then I became a part of the APRASIC group sort of as a result of being involved in this project. So a little bit on APSIG. We've been around since 2009. It was formed through the Australian College of Physical Scientists and Engineers in Medicine. So that's the College for Physicists, Medical Physicists. The primary role for APSIG is to recruit medical physicists as volunteers and to train local staff in, we've been to Cambodia, Vietnam, Myanmar, Mongolia, also PNG, and we have ongoing projects with with Laos and other groups as well. We support remote mentoring, so through the Iaea or more local networks, coordinate the delivery of donated radiotherapy equipment, and we support medical physicists from the Asia Pacific region to come here to Australia and New Zealand for conferences and specific in-house hospital training. So a little bit on the background, the Iaea regional cooperative agreements. That's the project that started in 2003. So this is an agreement between the 22 government parties of the Iaea. And this project specifically, 6038, looked at focusing on the medical physics education, training, certification, and recognition. Now, I wasn't well versed in this program before I got to Cambodia. We have our own training program, but got up to speed very quickly that clinical training programs had been trialled by the Iaea in the Philippines, Thailand, Bangladesh, and Malay region. And several clinical training guides were developed with major contributions from Australian and New Zealand physicists. There's clinical training guides, and they cover not only radiation oncology, but diagnostic radiology and nuclear medicine as well. The next project for the Iaea that started in 2014 was AMPLE, and that's Advanced Medical Physics Learning Environment. So that's an online training platform, but it's based on clinical training in the location. And so we structured a lot of the training based on this. That was quite straightforward to do because the Iaea clinical training guides are very much based on the Australian training online training modules. So this is quite familiar to me, and they had similar competencies and similar sort of learning progression. So I became enrolled as a supervisor, and Fanyat was my my student and still is. 2016, there were not a lot of medical physicists in Cambodia or Mongolia. You can see Australia is certainly flush with ROMPs, which is radiation oncology medical physicists, DR is diagnostic radiology and nuclear medicine physicists. Malaysia certainly benefited from the Iaea training programs, as did Bangladesh, and they have quite an extensive education program there. Cambodia and Mongolia, examples of countries that are yet to benefit greatly from a structured training program, and often their physicists would go to Malaysia to get their master's degree and some clinical training, but then come home to find you know, that was pretty much it. There just weren't a lot of resources to continue that training. And this is a comment I found. My colleague Anne Perkins gave this to me. I didn't. Vanyat had written pretty much straight up that medical physics was just fairly non-existent in Cambodia and not well recognised. So it was a good opportunity to go and change that a little bit and get myself over there. So I turned up, had 12 months at Calmette Hospital. I walked into a brand new radiotherapy centre to find top of the line equipment. And when I got there, there were a couple of Australian colleagues, an Irish colleague, so a radiation therapist and a physicist. They'd already been there for a couple of months. Kate was the radiation therapist and she continued on for another 12 months with me. Gary was a physicist who helped with the installation and just the acceptance testing of the machine. He had to deal with a lot of the logistics and obviously did a very good job of it. And you can see Vanyat's there in that photo on the left. So when I got there, a lot of things had been ironed out, but certainly there wasn't without challenges. So my project aims were very much given to me by DFAT in a lot of ways. One of the first priorities that I was told to concentrate on was to gain the trust. Sorry, I'll move that off the screen. Gain the trust of people that I'm working with and I'm teaching, because without that, I really wasn't going to get anywhere. So DFAT had made, or AVI had made that quite clear for us, and that to take our time to be involved in the department and sort of get involved in the culture, which was just as important as actually getting the work done. So another aim was to engage the centre to adopt a style of treatment that embraced the technical but put their patients first. So technical treatments, it was not a familiar space for them, and suddenly we had to really increase the focus on getting the measurements and the accuracy of the treatment as good as we possibly could. I was only going to be there for 12 months, so everything that I taught had to be sustainable and to continue working without me. And also had to learn very quickly about existing systems and how to complement those with the radiotherapy program. So being mindful that I was in fact not there to do the work, but that I was the medical physics trainer, I was not there to perform the work. My job was to teach and to show and to guide Vanyat predominantly, especially at the start, and then the radiation therapists, the nursing staff, and the ROs on how to go about setting up a quality assurance program and that would support a treatment program, one that they were comfortable performing, one that was reproducible, and then if they did get the results that weren't within spec, what to do with those results and how to interpret them and troubleshoot. But what if the way I've learned things and the way I teach things is not quite the way that the local people had grown up learning and understanding? You know, a lot of the radiotherapy world is very heavily regulated, especially the physics space. We have international regulations and guidelines which really do structure and keep a consistent approach to radiation oncology and to the therapy. So there are guidelines out there, but they're technical and they're in English. And what if your staff, you know, it's not their first language and they're not used to reading highly technical documents and really not so keen on doing so. how do they, you know, interpret those words into a way of analysing the numbers and the data that they're getting. There was a whole range of technical skills and experience. Let's say there was quite a limited range in technical skills and experience. And certainly the one big challenge I had was with the mode of learning. So in Cambodia, the schools are all very much have a didactic approach to teaching and to learning. So when the teachers, you know, especially with physics, if the answer to A is X, then there is no other answer, and the students are not in a position to ask questions or to show that they don't understand. In fact, to ask the teacher a question is to show disrespect. And so it certainly it was a very different way of learning, and one that I had to wrap my head around quickly before I could actually get them to ask me questions. So we did a lot of exercises in asking questions so that I could know what they didn't know, and so that I'd had a sort of an idea of where we were starting from. Because you have a room full of very polite people just nodding at you doesn't really give you much indication of how much is sinking in. Hierarchy, you know, medical physicists, we don't exist in Cambodia. It's not really a recognized profession. Radiation therapists are in the same position. Kate had an enormous challenge with her role. So if there's no position in sort of in the cultural, the hierarchical structure as there is for, say, for a doctor, really, who was this middle-aged white woman turning up to their department? Sort of, why should they listen to her? You know, that I'm sure they didn't ask that, but culturally it was it took several months before I realized I'd been accepted, and that I had passed some of the cultural challenges that I did not realize I was being tested for. But I honestly think that one of the things that worked for me was that I brought my family. I brought my kids. I brought my husband. We got involved in the schools, and people really started to feel that maybe I had skin in the game. You know, I was there. I was actually there for a reason, and that there was no personal gain from it that might be, you know, disingenuous. So I got there, and it probably took me about 3 months to get to a position where maybe some of the people higher up in the hierarchy would stop and listen. And certainly I used the RO contacts such as Iain to help me with because he automatically had quite a high status, and so that was very, very useful for me to get my message across if needed. So there were plenty of challenges. There were so many challenges, and there were certainly really, really difficult days. One of the ongoing challenges was the environment. It was so hot and it was so humid, and equipment, it really does depend on a stable environment. And, you know, the day I walked in and all the doors had been opened and the air conditioning was blaring and there was water pouring down the walls, and I just, you know, the amount of jumping up and down I had to do to get people to close doors just to and to stop playing with the air conditioning just to keep the equipment stable. That was one of my first challenges. Language, a lot of the technical words that we use in medical physics just don't exist in the Cambodian language. So there was a bit of interpretive dance that had to be done in order to explain things. And the other one that I ran into was a lot of regulations. So as I said earlier, there are plenty of regulations that help and guidelines that are international and published that help radiation oncology physicists with their work. And, you know, like we have radiation protection laws, but in Cambodia, their laws are more cultural. And so, and they're not so much written down. So a lot of Westerners break these laws inadvertently, or, you know, because they're careless. So, you know, there were no rules on the roads, or so to speak. So it was very, very hard to use any form of regulation or laws to actually bring focus to the safety of ionizing radiation, which in itself is quite a big area. So that was challenging, but certainly, well, had to. We got there. International experts flying in and flying out. I think definitely the benefit of long-term engagement really shone through in that 12 months, and obviously the work done years beforehand really showed that there was that ongoing commitment. Cambodia has a lot of people coming in and coming out to, to, so to speak, help, but that did often cause confusion. So having the Aussies there as a constant really worked. Okay, we had some great successes. We commissioned the CT scanner, the LINAC. Vanyat did all the work. I did all the guidance and structured it. And he really just such a hard worker. It was such an amazing project. He really should be proud of himself for having set that up. We set up the gamma med and the brachyvision, and as May said, we started treating 3D conformal at the end of March, and then brachytherapy at the end of September in 2018. So you've seen this photo in May's slide. It is really one of those photos that truly reflects the joy of the moment. We had just finished treating our first cervix patient, and it had been the first brachytherapy treatment in Cambodia since the 1980s. There was so much work involved in getting this team, radiation oncologists, therapists, a nurse, and physicist. It took a lot. It's very resource intensive and took a lot of teamwork and cooperation. Super proud to have been part of this team for sure. Really glad we got that off the ground as before I left. So lessons learned: take the opportunity when you can, find the opportunities to teach safely and balance learning for themselves with direct instruction. So, letting them make mistakes to a point was very, very useful. But then again, we did have to be creative with our learning opportunities. Structuring a lesson just didn't work. You just had to take the opportunity when you had the right people in the room. Other benefits of being there for the long term: have the big picture, you can compartmentalize the learning and the teaching, and you can see how the roles integrated for them, which would be different set up in a different to here in Australia. We had to use some creative solutions. For example, you can see a little Lego linear accelerator that I built for training in the planning space. That's Glenn. He was the second RT that came from Townsville, and he took over from Kate. So yeah, we used Lego there, and then the esky on the bottom right there is from the local vendors. It was the only way I could keep some of the equipment under some form of temperature control to stop the humidity affecting it. So I built trusted relationships. I got daily access to staff who were maybe lower in the hierarchy, which allowed me to empower them with some informal training, especially in the area of radiation safety and technical skills, which is really, really important. I introduced them to problem-solving techniques, opportunities to teach lateral thinking, spatial reasoning, and really the main aim was to give staff the space and the freedom to ask questions, and that was very much encouraged. I tried really hard to develop a no-blame culture across the department, whereby errors were seen as learning opportunity rather than a shame or a losing face type scenario. And it was a genuine contribution to a cooperative program that had been established by doctors such as May years earlier, and it was a really good way to consolidate the project. I got a great side trip to Mongolia to do a week of teaching. Really, it was a fantastic year. My family had a brilliant time, and certainly we got involved in every cultural opportunity that we could, and we still talk about it today. So thank you. I'll now hand over to Iain.
Thank you, Nikki. Yes, so I'm just seeing how I can advance my slides. There we go. So my role this afternoon is to talk about online networks and then a little bit about encouraging research endeavours in our neighbouring low and middle income countries. As Nikki particularly, and also May, have emphasised, most of the successes that we've had have come from direct engagement on the ground. APRASIG has, for the last few years, made a number of visits, spending 1 to 2 weeks at a time, either at the National Cancer Centre in Mongolia. We've also visited centres in Vietnam, Papua New Guinea and Mongolia, as Nikki said. However, in these times of COVID, we've had to find other ways of working. One example is this is here. This is a picture of the Port Moresby General Hospital, where there are 2 clinical oncologists who are waiting for a linear accelerator to arrive. In the meantime, we've been, well, 2 of our members, Jonathan Ramsey and Madhavi Chilkuri, have been supporting them and maintaining their clinical skills through using a cloud-based version of a radiation treatment planning system to outline target structures for radiation treatment and to critique them and discuss the pros and cons of the decisions that are made. To try to take this further, as May said, there were plans for volunteer radiation oncologists and radiation therapists to visit Cambodia last year to help them implement IMRT, so a more high precision radiation technique than the current 3D conformal radiotherapy, which is used. And Mongolia is also wanting to transition from 3D conformal radiotherapy to IMRT. There are a lot of potential pitfalls here. There needs to be a very high quality assurance program. There's a lot of potential for doing harm and missing targets or causing damage to normal tissues. And so it's very important that such a program be introduced under controlled conditions with adequate training. We have plans, we've managed to obtain funding to start a virtual training program to deliver in collaboration with our physicist and radiation therapist colleagues, some virtual training to assist Cambodia and Mongolia in making this transition through virtual training, online meetings, and a cloud-based platform also to share learning materials. Many of our colleagues in low and middle income countries do not have access to multidisciplinary meetings that we take for granted to discuss difficult cases. Many of the radiation oncologists work in small departments. There may be only 1 or 2 radiation oncologists in the country. Even before COVID, they had limited opportunities to travel to conferences, and so often they were trying to treat often very complex patients without much peer support. APRASIG has been leading an International Atomic Energy Agency project for the last year to provide virtual tumour boards where we have monthly case discussions of difficult cases. We meet using Microsoft Teams for an hour once a month, and we discuss 2 to 5 cases each time. The cases are predominantly chosen to reflect the difficulties that are experienced in low and middle income countries. We take minutes, and these are archived for future reference, so hopefully there'll be an ongoing resource for teaching and learning. So the countries involved in this project are the regional cooperative agreement countries that Nikki mentioned. So from Pakistan in the northwest, New Zealand in the southeast, Mongolia, Japan, Australia, and Southeast Asia. So we commenced these meetings in November last year. The first meeting had 21 participants from 15 countries, but as you can see here, there's been a rapid increase over the year, and last week's virtual tumour board had 104 attendees. What's been gratifying is the number of trainees who've been attending, registrars and residents, and we've had between 30 and 50 residents attending recent meetings. The number of countries involved has stayed reasonably constant at between 14 and 18. So we usually, as I said, discuss 2 to 5 cases at each meeting. And so far we've discussed 34 cases. All of the clinicians who presented the cases felt that it was useful exercise in helping and supporting their decision making. And interestingly, in more than half the cases, there were changes to some aspect of their management. Not surprisingly, there's a lot of breast cancer and head and neck cancer discussed, but we were surprised at how many sarcomas were presented. And I think that probably reflects the importance of multidisciplinary management of sarcomas. Indeed, all of us who treat sarcomas in Australia and New Zealand acknowledge how important multidisciplinary consultation is. And so it's very difficult for people who are practicing without the backup of a multidisciplinary team. Next week, we're going to have a review of our first year's experience, and we plan to expand the project to include online review of target delineation and also radiotherapy plan comparison to try to improve the quality of radiotherapy plans. We're also going to be expanding the meetings so that there are meetings for physicists and radiation therapists. So just briefly a discussion about research. As May has mentioned, in low and middle income countries in our region, often oncologists encounter different problems. There is a different spectrum of disease, often different comorbidities, and of course there are different social contexts. And yet the guidance, the standard of care that's been developed is often in high-income countries, is often all the guidance that, that clinicians have. And so often there's necessity for ad hoc treatment changes, often with a low evidence base. So it's really important to look to try to improve the evidence underlying treatments that's offered in the low and middle income country context. APRASIC has tried to promote research. Last month, Ling was the guest editor of a special issue of Jamiro, our college journal, on radiotherapy in the Asia Pacific. And we've also published in other international journals. But it's very important to try to support our colleagues to build a culture of research. And Nikki has commented on how adaptable and resourceful the clinicians are, physicians, radiation therapists, in treating patients with limited resources. But in order to, but there's a need to provide a strong evidence base for this. One way that we are looking into is to help departments use the data they're already collecting for their electronic patient management systems that they need to run their Linux to use to establish baseline data to measure improvement and establish priorities. And so we hope to get funding from the Iaea to do this. We acknowledge that oncology or radiation therapy, radiation oncology is just one part of the cancer care continuum. And we need to make sure that we engage with other professions. As a first step to this, we've been involved with setting up a global oncology group under the banner of COSA. And just last month at the virtual COSA annual scientific meeting, this COSA Global Oncology Group was established. It largely involves medical oncology and radiation oncology at this stage, but we are very keen to expand this to include pediatric oncology, Michael, as we were discussing. It's important to involve surgical oncology and radiology, pathology, and all the other professions which are involved in providing cancer care. So I want to leave time for discussion, so I think I will stop there. I'd just like to acknowledge the work of many people who've gone into the work that we've tried to showcase this afternoon. There are too many names to go through all of them, but suffice it to say that we are really just the flag bearers for the hard work that a lot of people have engaged in. Thank you.
Thank you, Iain, Mei-Ling, and Nikki for three really enlightening presentations. Now, if anyone has any questions, can you put them in the Q&A, and I'll direct them to the presenters. But perhaps I could begin while we're waiting for additional questions. And the great challenge we have within Oceania is the absence of radiation for Pacific Islands and Papua New Guinea. I think we have a population of perhaps 10 million people with currently no functioning radiation available. Where do we start?
Well, I'll make some comments to start off with, but Nikki and Mei-Ling will probably have lots of ideas too. Radiotherapy is difficult because it requires a whole lot of things to come together before you can have a functioning service. And so not only do you need the capital investment, but what's the biggest challenge is getting the training and coordinating the training of the doctors, the physicists, and radiation therapists, and nursing staff as well, because they're all essential for the delivery of treatment. It's difficult. Papua New Guinea has had some very effective training scheme for radiation therapists, but then they didn't have physicists, and they had only one radiation oncologist for many years, and so unfortunately, the radiotherapy, having been in Papua New Guinea for decades, the service fell over and hasn't started up again yet. I think ideally you need to get all the training of all professions coordinated so they can all start at once, but that's very challenging. It can be done, but it requires a very coordinated central government response, I think, and that can be difficult, especially when there are other problems with many competing other things that compete for government's attention. Another approach is to bring in a whole team from outside, which has its dangers, but I think the flagship for that approach was Botswana. I think, Mei-Ling, you know a bit more about this, but I believe that a private company came in, started up a cancer treatment centre, a radiotherapy centre, and then over a period of years, progressively handed it over to the local government, and so now it's a fully publicly run service. But there are lots of challenges, and we haven't solved this yet in the Pacific.
A question perhaps to Mei Ling and also to Nikki. The notion of in-country training to prevent what's called a brain drain, but is really an opportunity drain, isn't it? Getting in-country training is a really important notion. How do we how can we support those people being trained in country to get their qualifications recognised and the training recognised by authorities, etc.? Is this something that needs to be sort of set up with in anticipation of starting training, so you don't just have ad hoc trainees? It's very complicated, I should imagine.
Oh, I think you'd need someone who's an expert in politics and government negotiation, as opposed to a physicist who does. I think it's very much about who you can get to make those sorts of influential, have those influential conversations. Certainly, it's a challenge. It's a really big challenge. One I don't have an answer to, I'm afraid.
Yeah, I mean, I know there's another, there was I think Stephanie was involved, one of Nikki's colleagues, a physicist, in helping train a physicist in one of the countries in the Asia Pacific, where they sort of spent time in France, and then also that French physicist also spent time in country, and then that physicist was able to have the French qualifications. So there have been some models set up where, you know, a local physicist can spend time both in country and then out of country to get qualifications. But yeah, certainly it is a challenge. The colleagues of ours in Cambodia, in terms of physicists and radiation therapists, as far as I'm aware, they don't have formal qualifications, even though they have undergone the vigorous training that Nikki and others have provided. So yeah, it certainly is one of the challenges that we haven't completely ironed out. The Iaea sends fellows abroad to, you know, neighbouring countries to have training, but for example, with the radiation oncologists, often they will get formalised qualifications in that country where they've trained, but that's not always the case for all the professionals.
One observation we've had pointed out by our colleague in Cambodia is to get trainees in paediatric oncology, you have to convince some trainees to not just do general paediatrics and go into paediatric oncology. But if they do that, they then don't have private practice for which they can then feed and clothe their families because the hospital salaries are so poor. These are really important practical challenges.
That's right. I saw, so my therapists were trained originally in the diagnostic setting, and they came across to the radiation therapy setting, and they suddenly their pay dropped significantly, their status dropped significantly. The colleagues they left behind were doing great with their private contracts, and they just weren't getting the recognition. And I think that was very demoralizing, and certainly not, you know, they couldn't afford to have a family on the wages that they were getting. Certainly with the physicists, I know that Van Yat had somehow managed to get a government position. And so this is, I mean, this happens in a lot of the areas. If you be one of the physicists I was trying to recruit and train when I was over there, she actually took on a teaching position, because if you get a teaching position through the government, then you're set for life. And why wouldn't you? You get a wage whether you turn up to your class or not, really. And so why would you risk jumping into this new area, into, you know, medical physics, which is probably where she wanted to be, if she wasn't going to be guaranteed a wage and a career. So yeah, that was certainly at every crossroads, there was a challenge.
And even the medical staff, you'd think they would be well remunerated, but all of the radiation oncologists bar one are doing private practice in general medicine. And I think most of the other doctors are also, have some sort of side occupation basically to supplement their income from the public.
Well, we've just come up to just after 2 p.m. And I just wish to thank our three presenters, Iain, Nikki and Ling, for a fantastic presentations. And there's obviously lots of work to continue to do, and particularly from our area, very enthusiastic to collaborate. So thanks very much for your presentations today.
Thank you.